Dr. Mrs. They are radiotherapies. Most of the breast consultant surgery, after that one will give radiotherapy. The primary site wave insides, that part becomes the hard feeling for years. And the patient becomes unnecessarily apprehensive that there is a recurrence. How to follow up this patient? Every time do need a FNSC or do I advise a mammography, or how to follow up that patient?
Actually, if the fibrosis is too much, then it's very difficult to find out. Like we had a patient like that, where we thought that it's a fibrosis of the breast, but then it slowly we found out that it's a recurrence. So in this sort of patients, it's very difficult to find out the time of recurrence actually. So if we have to, there is no clear-cut investigation, right? We can prove that it's a clinical judgment altogether.
How do clinical differentiate? Because both are feeling very hard. Because patient comes every 3 months, we follow up for first year. Yeah. And every time you advise a finishing or you advise a ultrasound, or how to know actually. You cannot leave the patient for 3 months and the patient can come back very recurrent. Then it will be the doctor and you cannot detect.
It's very difficult to find out. There is no clear-cut thing that we can say. Only that the size of the breast is becoming more, or it's a painful site. The pain is increasing. That's a way to find out.
I think this is an important question because it also, in fact, raises the issue of quality of radiotherapy, and the best way to do it is to try and avoid getting these kind of results. Now, obviously, occasionally one may get it, but then I think if you have older techniques and poor quality radiation therapy, this is a problem which is going to be seen far more often than if you use modern radiotherapeutic techniques. So this would then be an occasional problem. But if you actually go by poor quality radiotherapy, then I think these will be got much more commonly. And therefore, I think one has to be careful while advising radiotherapy or breast conservation as to the quality of radiotherapy set of services that are available in the center.
Hello. Sir, what should the margins in conservative breast therapy? 1 centimeter or 1 inch? Or anything in between is fine. In what should the surgical margin in breast conservation therapy? 1 centimeter or 1 inch? Anything in between? Because so many papers give some margin, 1.5 centimeters.
Yes, you're right. I think there are many papers which say will give various margins, but I think at least a 1 centimeter margin should be a minimum 1 centimeter margin should be tried to be achieved. And of course, as Dipendra very rightly pointed out, that if the margins continue to be positive even after 2 excisions, then this is a candidate which is not fit for conservation therapy. Another point, I think the only point that he possibly did not highlight, otherwise I think it was a wonderful lecture, was that whenever one is going for breast conservation surgery, I think it's imperative that we do a mammography of both the breasts. So, the presence of multicentric disease is a strict no-no for breast conservation surgery.
Sir, a young teenage girl coming with a small breast lump, should I go for ultrasound, mammography or FNSC?
A young teenager means strictly speaking 13 to 19. I would rather suggest not to go for mammography as a radiologist. 13 to 19, I will always suggest you first clinical breast examination followed by ultrasonography. If you are still in doubt and the patient can afford, MRI will be the best method of investigation. The only problem with MRI is that it gives too many false positive reports. About the first question coming up from the audience, that how to differentiate between really a fibrosis or a recurrence or like that. Again, MRI is definitely the choice of investigation. Please remember this. MRI with contrast. Breast MRI without contrast is not possible. You cannot have a plain MRI of breast. It has to be a breast MRI with contrast. And with contrast, for recurrence, for multicentric breast cancers, everything. You can find out almost everything in MRI. Again, I am saying there are 2 difficult things. One is the cost is prohibitive, and number 2 is too many false positives.
I would also like to take on that question. Basically, this is a teenage girl. This is a category where you hardly a small mobile lump in a teenage breast. You actually don't need to do anything much. I mean, at best you can do an ultrasound. If it cysts, you can aspirate it, and then if it refills, you can excise it. But apart from that, if it's a solid tumor, I think you just need to go in and excise it. I don't think we need to do any investigations in a teenage. If it's a big lump, you're really doubting something, very serious family history, I don't know, maybe. But for most teenage girls, these would be absolutely benign lesions. So I don't think we really need to go very deep into these patients.
I just wanted to comment on that.
Just one second. What Dr. Malhotra said, that I said also that clinical breast examination is the most important, and why teenager till the age of 30 maybe. The clinical breast examination, number 1. Number 2, mammography is almost not done in a teenager. If you are still uncertain, go for an ultrasound. Breast cysts are not that common in teenagers, but more common in the menopausal or perimenopausal age group. So fibroadenoma will be the most likely diagnosis. And please, you are a surgeon, please use your surgical experience, surgical expertise to say it is a fibroadenoma and nothing else.
Second thing I would like to add on, that in a teenage girl, we will go for FNAC, not for any radiological investigation. Even if it is cyst, it will be aspirated, it will be giving a liquid fluid. And we can submit it for a psychological slide examination. But we need not have any radiological investigation in that patient, 13 to 19.
In fact, I would go to the extent of saying that in a teenage girl with a breast mass kind of lump, you don't even need to do an FNAC. You don't need to do anything. You just need to take that lump out. That's all. I mean, it's hardly ever. I don't think any of us would have seen malignancies in teenage girls.
Just one more question.
So normally they come back actually with another lump. Each time you don't remove everything.
FNAC is then
they come back with second or third lump in other way standard.
See, basically you are talking about multiple adenomas. Well, then you can counsel them and say that this is a small breast adenoma, and you can just stay with it. And that's obviously one option.
So my question is to Dr. Mahapatra. In case of chemotherapy, what should be the optimal duration?
Optimal duration.
Optimal duration.
This is chromatic number 6. We see this patients we can give basically 4 cycles or FSA 6 cycles, but minimum is 4 cycles of chemotherapy. That every 3 weeks, 4 cycles is the minimum. But again, the European group varies from US oncologists. They say probably 4 is enough in US, but European group they say 6 should be the standard. So duration varies.
There is still debate regarding continuous chemotherapy and intermittent chemotherapy. Does intermittent therapy has got any advantage over continuous chemotherapy?
Are you talking about the weekly treatment, or you're talking about continuous chemotherapy?
No, I think if I get you right, basically what you're talking about is in metastatic disease, because that is where sometimes you don't know when to stop, whether you go on continuing with it till the patient is responding, or whether you give it a gap or something. Generally, that's not the case in early breast cancer.
I think adjuvant treatment has got standard treatment.
Yes.
You are treating.
Second question is to Dr. S. Das. Do you advocate mammography in pregnancy?
Generally, in general, the answer is no. In general. But if you take proper precaution and you badly need a mammography, then you can do it. But again, if you have a choice of MRI, you go for MRI because MRI has no radiation hazard that way. But if you think you have to do a mammography, then take proper precaution, like you use all the guards possible in your department. As a matter of fact, we have done 1 or 2, but that is not a very right procedure.
In fact, I think when you refer to mammography in pregnancy, it would not generally be of the screening types. That would be patients, I think, who are already diagnosed with breast cancer. Obviously a pregnant woman is likely to be younger, and she may want her breast to be conserved at all costs. So these are cases where you may consider doing mammography just to conserve her breasts. obviously this is not a case for screening mammography, because I mean you could always, if a patient is normal, asymptomatic, you need not go screening her while she's pregnant. So these would be cases where a patient is diagnosed as having breast cancer and she insists on having breast conservation surgery. So these are cases where you can take proper precautions and do it. Otherwise, as he has very rightly pointed out, these are the cases where maybe MRI today would be more effective.
But these are young, so we can do away with the USG breast.
Again, the USG breast is basically an adjuvant to mammography. As Dr. Malhotra said, that if you are sure that this patient has a lesion, USG breast is definitely advisable, but USG breast is always considered as an investigation for a targeted, it's a targeted investigation and not a non-targeted investigation. That means if you are sure that there is a lesion, USG breast can give you lots of information. If you are not sure whether the patient has any lump or not, then USG breast is not considered as the primary choice of investigation, neither as a choice for screening nor as a diagnostic procedure. There is a difference between a screening method and a diagnostic method. Come to think of it, ultrasonography guided aspiration is a definite method of investigation for breast cysts. It not only gives an investigative measure, it also treats the patient sometimes.
I just wanted to know one more thing, sir. Sir, in a patient who is pregnant, what the doctor asked from you, they are usually below 40 years of age. And we usually, the people, even the radiologists say that the person who is less than 40 years, the female who is less than 40 years, mammography will not result or will not give good result because they are very intense stress. So, in our setup, we are using ultrasonography, ultrasonomammography as an investigation of choice for those patients rather than a mammography who are less than 40 years. Because every time we send the patient to the radiologist, the report comes that the breasts were dense and we cannot report on mammography, and they advise ultrasonomammography instead. So we have made it a rule that we are above 35 and below 40, we are using ultrasonomammography first, and it's doing good for us.
Yeah, but these are patients who have lumps, right?
Sir, even the patient who are having this, the bloody discharge from the nipple, or the patient who are having
lumps. So they have symptoms. They
have
a symptom.
Yeah, without symptoms, we will not do it. Screening wise, that is not required.
It's not routine.
Below 40, it's not required.
One basic question. Amoxicillin